Good morning. My name is Nicholas Robbins. Thank you for this opportunity to present here in this venue. I'm currently a research fellow at the Restore Lab, as my colleague mentioned earlier, Dr. Wu. We're working up in San Antonio with Lieutenant Colonel Michael Davis, and the topic of my presentation today is listed, and as mentioned earlier, I have nothing to disclose today. And as my colleague mentioned earlier, some of these slides are briefly similar to his talk, just to kind of describe why VCA. So as this graph was shown, in 2006, during the Afghanistan and Iraqi confrontations, with the change in trauma resuscitation as well as improved body armor, we saw a decrease in case fatality rates, while the injury severity score slightly increased. Primarily within extremities as well as maxillofacial trauma. Further discussing, touching on these social implication-wise, from the military standpoint, congressional estimations that showed that there were greater than 1,500 American soldiers who faced traumatic extremity injuries during these confrontations, and it's estimated to be slightly greater than $600 billion of lifetime healthcare costs to those soldiers. On the civilian side, traumatic amputation or extremity injury is actually the second leading cause for extremity amputations, first being diabetes, of course. It's greater than 700,000 occur of these each year in the United States, and in 2013 alone, hospital charges were estimated to be approximately $8.7 billion. So this led us to our lab to the development of a couple different VCA models or vascularized composite allograft models, because in the plastic surgery world, it's ideal to us to replace like with like. And so that's our intent of evaluating these in the lab and then taking them to the clinical patient, as well as you've seen in the media. So in this particular model, we developed a myocutaneous flap, which was the semitendinosus muscle. And this was initially developed back in 2012 by my colleagues listed here and published. So in this particular experiment, we actually used the heterotopic autotransplant. As you saw earlier, we have the capability of doing allotransplants, but because of this, it was only an autotransplant, these animals did not require any systemic immunosuppression or local immunosuppression. So briefly, to kind of go over the model, we derive our semitendinosus flap from the left hind limb, using a terminal branch off of the profunda artery for our vascular pedicle. And it is a myocutaneous flap, so it has the skin island, adipose tissue, the semitendinosus muscle bulk with the vascular pedicle that you can see there. No bone is involved in this model. The recipient site, we then create a midline incision over the trachea, dissecting out the right internal jugular vein as well as the right common carotid artery. We then inset the flap using microsurgical technique. On the vein, we use a venous coupler, usually 2.0 to 3.0 millimeters in size, and then we'll use interrupted sutures to anastomose the artery under the microscope. But before insetting the flap and after harvesting the tissue, one of our primary areas of interest is mitigating the ischemic response and the inflammatory response in inset in the in vivo setting. So if we can minimize that in the ex vivo setting and then implant it into the patient or the animal, and in this case, we can hopefully decrease the need for higher doses of immunosuppression. So in this particular experiment, what we looked at was using an 8-hour hyperbaric normothermic at 37 degrees Celsius hyperoxygenated environment for the flap. And so in these photos here, you can see our hyperbaric chamber, which we take up to about 3 atmospheres of pressure. The artery is cannulated with a 20-gauge angiocatheter hooked up to a perfusion line, which we're perfusing kidney preservation solution that's hyperoxygenated. The venous side is then passively draining into a basin that's just sitting below that white grate you can see there. And the flap sits in that chamber for approximately 7 hours, and the last hour, the 8th hour, is actually during anastomosis time, so a total of 8 hours of ischemia. To further discuss kind of our model, our control, we had an N of 6, and for the controls we did cold static preservation using University of Wisconsin solution at 4 degrees Celsius, which is actually currently the clinical standard of care. We took it out to 4 hours. Our lab previously assessed taking it out to 6 hours, but the swine tissue was just unable to handle that, and it created a non-viable flap, completely dead by day 7. So this was the maximal time that we could take it to create a viable clinical standard of care flap. The next 2 groups are experimental groups, which are exactly the same. The only difference was the endpoint. The N of 8 we took out to 14 days. They did so well. We wanted to see if we could take it out further and see if there was any effects. So we took it out to an endpoint of 21 days, and all of them experienced the same number of hours of ischemia, so 8 hours at normal thermic temperatures. So to discuss some of our data, the top 2 graphs here show LDH and AST, so a few of the markers that we look at for signs of tissue ischemia. The red line is representative of our controls, and the blue line is representative of our experimental group. And these are the means at the postoperative days. So we assessed them baseline, immediately post-op, and then post-op day 1, 2, 7, 14, and 21. I don't have statistical data as of yet, just because we're compiling all the data, but but what I wanted to show you today or impress upon you is the trend that we're seeing. We're seeing quite a big difference in a decrease in these markers during this time point that we can correlate well clinically as well as with histopathological evaluation. The bottom 2 graphs, we looked at IL-6 and TNF-alpha, which are also markers for inflammation. And IL-6 correlates well with the top 2 graphs, whereas TNF-alpha, though it doesn't look significantly decreased compared to the control data, what is significant is it's that showing that there is really no difference between the 4-hour standard of care versus our 8-hour experimental treatment. So from the clinical side point that we see on our postoperative days, these are our control flaps, different days, so 0, 7, and 14. All of these flaps were viable with no signs of necrosis at the endpoint. Compared to our experimental flaps, as you can see here, all of these are different flaps at different time points. But again, we saw no signs of frank tissue death or necrosis, and all flaps were considered viable at the endpoint of the study. And lastly, just to kind of go over some of the histopathological slides that I briefly mentioned, the top 2 slides are from our control flaps, showing our muscle and then our skin and adipose tissue. And the bottom is a comparison with our experimental treated flaps at the 8-hour ischemic time point. What's important, these were biopsies taken at the end of the ex vivo phase just prior to reperfusion. And so what I wanted to show you here today was the minimal inflammatory effect that you see there. And what's also incredibly important is that the muscle itself is showing no signs of necrosis. It all looks great and healthy and ready to be implanted. Typically, beyond the 4-hour time point of our current clinical standard of care of cold static preservation, you tend to begin to see signs of necrosis within the muscle. So in summary, we believe this technique has the ability to extend the viability of our tissue or VCA in the ex vivo setting. It decreases or mitigates the secondary effects due to ischemia, as well as to cold preservation technique injury that is often seen. It extends the time period between procurement and transplantation, which is profound because it can increase our donor pool, allowing us to better match patients as well as decrease the current geographical barrier that we're constrained to. And lastly, we believe this has broad implications across the entire transplant field and not just the VCA field. On our future direction, once we finish our 8-hour data points, we're going to actually extend our ischemic time up to 14 hours because we actually don't feel that we've met the physiological barrier with this current hyperbaric method. Thank you. I'll take any questions.
I was just great work, absolutely. And it's very interesting what you mentioned there in the end about extending it to 14 hours. I guess my question would be, it seems from how you presented in the background that this intent might be able to be for, battlefield potential
Correct.
salvaging, especially with the Autotransplant model. I guess my question would be, if that was the intent, then what's the logistics about being able to use hyperbaric in that sense from when they're coming to where they're going? Or if it was for transplant, then would the intent then be to do an allotransplant model so that you could more mimic what its future use would be?
Yeah, exactly. So it's a great question, and that's kind of we have several different studies going on in our lab currently assessing different ex vivo preservation techniques for both the allotransplant world, but also for tissue sparing operations. So if a soldier were to lose an extremity, and we could ideally place that extremity in an ex vivo preservation system and transport that tissue with the soldier, or if, God forbid, the soldier were to pass away, we could still preserve aspects of that tissue, preserve it in this machine, and then fly it to wherever we need to. The logistics of having a hyperbaric chamber that size and transferring the tissue from the battlefield to a hospital in Germany is actually, is something of importance to us. And so we are currently working with a number of bioengineers to shrink down that system. And also we have some collaborators that we're going to be evaluating our systems within a hyperbaric chamber. So during flight, or a hypobaric chamber, so during flight, how will that affect the tissue and the environment, that local environment within the system? So those are all things we're currently evaluating.
Have you looked at any other ischemia time before going into the hyperbaric chamber? I'm just thinking of this from a civilian perspective, right? If you're going to go procure organs from X hospital, they may or may not have hyperbarics, or if you don't have your kit yet, what about timing?
Outside of the hyperbaric chamber?
Outside of the hyperbaric chamber before getting it into the hyperbaric chamber. Have you looked at any of those?
So initially our control, in setting up the model, we evaluated different controls. We used hep saline, then we went to the clinical standard of care using cold static preservation, and we assessed different time points, and that's when I kind of briefly mentioned that 4 hours was kind of the maximum, at least for swine tissue, that we could preserve tissue and still have it being a viable tissue that we can implant, either auto or allo transplant. So we've done that, and I think that you could potentially just do the current clinical standard of care once it gets to the center. As long as within that time point, you could then put it in the chamber, but we haven't assessed kind of that transition 4 hours and then put it in the chamber.
Sure.
But we do have different preservation ex vivo machines that we're also assessing with acellular oxygenated fluid at different temperatures as well. So kind of approaching different aspects. So.